So this patient, in most cases, will have settled down. Within a week, the symptoms will go away. As the old adage goes, that if you treat a common cold with medicines, it will take 7 days. And if you do not treat it, it will get better within a week. So, but if this patient does not improve, on the other hand, starts deteriorating, the fever starts becoming high grade, and a thick mucopurulent nasal discharge starts developing, then in that case, this patient is heading towards a bacterial sinusitis. Next. Now, an acute bacterial sinusitis is essentially a clinical diagnosis. So there's really no role of a radiology or a microbiology in these cases. X-ray paranasal sinuses used to be very popular probably 15 or 20 years ago. But we all know that as ENT surgeons, that there's very little information that one is really getting on that. And a CT scan, which may be diagnostic, must be used extremely judiciously. One should not be advising CT scans left, right, and center for a pediatric age group. Although now with the CBCT available, the cone beam, where the radiation exposure is 1/10 of a regular CT, we would prefer using that, but again, only when strictly indicated. So what are the causative organisms in cases of acute bacterial sinusitis? So the most common culprits are the strep pneumoniae, the Haemophilus influenzae, and the Moraxella catarrhalis. These are the three common organisms which are the cause for not only sinusitis, but quite often the otitis media, adenoiditis, even for the laryngotracheobronchitis. Next. Now, it's very important that we treat these patients properly with a proper duration of management whenever an antibiotic is required. So the most commonly used being amoxicillin for 40 milligrams per kg per day in 2 divided doses for at least 10 to 14 days. Okay, unlike the tonsillitis or pharyngitis, where you would be able to get away with 8 to 10 days. But here it is preferable so as to make sure that the infection is completely taken care of. In case we don't find a good enough response, then an amoxiclav in the same dosage of 40 milligrams per kg per day in divided doses, or the cephalosporins. Cefpodoxim is a fairly effective molecule, 10 milligrams per kg per day in divided doses, or a cefuroxime, 30 milligrams per kg per day in 2 divided doses, or cefdinir would be equally effective, 14 milligrams per kg per day in divided doses. But remember, use the antibiotics here whenever it is required for a period of at least 10 days, sometimes going up to 14 to 15 days.